It is now my pleasure to turn today's program over to Amy Gibson. Amy, you may begin.
Thanks so much, Matt. Hi, everyone. This is Amy Gibson again from the National Learning Team, and thank you so much for joining us on today's webinar. So today's webinar is really going to be the first in the series where we're going to do a deeper dive into the 5 comprehensive primary care functions. And as Matt said, we're focusing today on care management. We know that already that care management is a high priority for many of you, and we really hope the information today helps you really get started on the changes you want to make in your practice. So let's do a quick review of the agenda to see what we're going to be talking about today. So just like you, we're committed to making ongoing quality improvement to all of our webinars. So please do let us know if we're fulfilling your needs throughout the webinar. But today we're going to be really hitting on some of the main elements of care management. We're going to do a quick review of the driver diagram, the change concepts, and those requirements that are part of care management in the CPC Plus model. We're going to talk about some of the differences between longitudinal and episodic care management, risk stratification, and then, of course, go and review those learning supports, because we know we can't cover everything that you're going to have to be working on to implement all the aspects of care management just in today's webinar. So we'll let you know some of those opportunities that are coming next. So we're super excited that we have some fantastic experts with us on today's webinar who are going to be sharing some really important information about care management with you. And they're going to be with us to answer many of your questions. Again, in the spirit of ongoing quality improvement, we're leaving more time for questions because we know you'll have a lot of them for today. So they're going to be with us. So again, as Matt mentioned, please do use that Q&A button and type in your questions throughout the webinar. We'll start to integrate those answers throughout today's presentation, and then again, have time for both the presenters, and our CMS team is with us today also to answer some of your programmatic and policy questions. So our speakers with us today are Dr. Asaf Bitan, a practicing primary care physician and senior advisor to CPC Classic and CPC Plus. We have Jen Miller, who helped facilitate practice transformation in CPC Classic and is now a member of our National Learning Team for CPC Plus. And of course, we can't do one of these webinars without some real practical examples and lessons learned from one of our stellar practices. We have Daniel Wilkes with us today, who's representing a practice and is going to tell us exactly what this really means when the rubber hits the road. What are the things you're really going to have to be doing when it comes to care management? So Daniel, let's go ahead and get started with you. Please introduce yourself. Tell us a little bit about your practice, your role in the practice, and then I'll tee up a couple questions for you just to get us started.
Okay, sounds like a plan. Thank you for the introduction. So we are a primary care clinic with 5 clinics in Southeast Portland metro area. We have just about under 30,000 total patients with about 28 practitioners. We use we use Entergy as our EHR, which is a Greenway product, and we'll talk a little bit later about the AFP risk stratified care coordination tool. Also, the last part I want to tell you about our group is that we were participants in CPC Classic. We had 3 clinics participating, and we're thrilled to say that now we have all 5 clinics participating in Track 2 of CPC Plus.
That's fantastic. So I'm going to ask you to go back in time a little bit, Daniel. Think about when you were first entering into CPC Classic. Tell me a little bit about how you're thinking differently about care management now in your practice than you were when you first started.
Oh, sure. So when we first began the program, forming our care team, our care coordination team, and how we were going to announce it to both the other departments within our organization and the rest of the medical community here in the Portland area, we thought we kind of had to do everything on our own. There was a lot of recreation of the wheel, a lot of, essentially building the airplane in the sky. And one thing we're really thankful for is these functions put on by CMS, the opportunity to learn from other groups. And it was absolutely crucial for us to put our workflow on paper and describe what exactly drives that workflow, which in our instance, which again I'll share later, is the risk stratification process.
That's great. And I know you've done so much over the last several years as part of CPC Classic and now moving into CPC Plus with your care management program. But if you could pick one element that was most critical to your success in providing care management services in your practices, what would you say it is?
I would say that, again, the creation of that workflow, it really gave the folks on our care coordination team an understanding of what the expectations were, what a regular day was, and it really made it easy for us to get buy-in from other folks too, because we could describe exactly what it is that we do and what they should expect with care coordination involvement with our patients' lives.
I think that's really important that you talk about that. It might not be the sexiest thing that you think about how you implement this as part of your workflow, but obviously a really critical element to implementing care management. So thanks for telling us about that. And we look forward to hearing more about your practical experiences as we go through this webinar. But I want to start here with a quick refresher on the driver diagram. So if we click over to the next slide. So on the last webinar we had, we gave this high-level overview of each driver and the primary care functions. Again, today we're going to take that deeper dive into care management. And as we've heard from many practices, integrating comprehensive care management had a very positive and strong impact on their patients. So we know that a lot of you are going to want to get jumping right on to a lot of the improvements that you're going to make in the practice around this function. And we know there's many factors that go into care management. So if we look at care management on the next slide and describe that at a high level, we're really talking about care management for high-risk, high-needs patients as a hallmark of comprehensive primary care. But within this function, we're asking practices to identify high-risk patients and high-needs patients to provide that care management support in two different ways. So the first is through that risk stratification of your empaneled population to identify patients that are most likely to benefit from that targeted, proactive, relationship-based care management. And in this model, we're referring to that type of care management as longitudinal care management. The other kind of care management is episodic care management. And this approach really involves identifying patients based on triggering events. So those events might be transitions of care from different settings, hospital, ER, skilled nursing facility, or even maybe a new diagnosis of a major illness. So providing short-term care management, really, regardless of risk status, is really important for those patients. So as we're asking practices to provide both longitudinal and episodic care management, targeting care management resources in both ways, that's one of the ways that they found during CPC Classic that really worked best to improve outcomes for the total population of patients. So on the next slide, we're going to review those requirements because we know that those are very important and help you guide a lot of your quality improvement work that you're going to be doing. And these were teased out for reasons of them having very high impact on improving care and meeting the aims of CPC, the CPC Plus model. So risk stratification of all empaneled patients. And as we talk about the care delivery requirements here, some of the other care delivery requirements that are not in here, of course, specifically speaking to the empanelment of patients, are important elements to care management. So just because it's not part of the care management delivery requirements doesn't mean you don't also need to do that, and it's also going to have an impact on your delivery of care management services. But risk stratification of empaneled patients is very important to care management function. Again, the targeted, proactive, relationship-based care management of patients that are identified at increased risk, that longitudinal care management, and then the short-term episodic care management. That includes the medication reconciliation to both the high and increasing percentage of empaneled patients who have those hospital admissions, those discharges and transfers from other environments of care, and those who you know are likely to benefit from care management, even in the short term. So again, it might be a new diagnosis. Patients, again, with ED visits, and then making sure that there's active, good, strong follow-up in a timely manner with patients who are leaving the emergency department and those who are leaving the hospital. And we heard on past calls that even a lot of practices are initiating care management services even before a patient leaves the hospital. So that's just the standard to go by, but doesn't mean we can't do better than that too. And then for those Track 2 practices, there's that additional two-step risk stratification process that we'll talk about for your impaneled patients. And then really integrating the use of a care plan. But all of this really is enhanced with Health IT for Track 2. So, just because it's in Track 2 again, doesn't mean you don't want to do it if you're in Track 1. The Track 1 requirements are really the foundation that the Track 2 requirements build on. So this is an enhancement of the Track 1 requirements. So we're all going to be striving towards those. So this is where I want to ask Asaf. So Asaf Bitan, you're a physician. You worked with CPC classic practices. I know a lot of people know you from your experiences there and through all your work and research on medical home. I want you to take just a minute to introduce yourself, tell us a little bit about your background, but then talk about why this emergent learning from CPC around the different types of care management has been really important to this model.
Sure. Thanks so much, Amy. Well, it's nice to be back with many of you all. You might have heard my voice or met me at learning sessions if you were practice in CPC Classic. For those of you that haven't met, we're just extremely excited to be working together with you all on this next phase in our journey to really improve primary care, to provide you with the resources to provide your patients and your communities with the outcomes and the type of care that I think we all want to provide. So I'm a practicing general internist in an urban area of Boston called Jamaica Plain. We have a clinic there that sees about 10,000 patients, or about 4.5 FTEs, and a lot of these, I would say, of all of the drivers, they're all important, but care management is sort of has a special place in our hearts as being so incredibly important to our shared goals, and I think our shared goals not just as a practice, but across CPC in providing our patients, their families, our communities with the kind of seamless, integrated care that reaches across the spectrum and the care continuum that is there for our patients and families when they get sick, that anticipates elements of the post-discharge process that are, from your practice and your life, as family members and patients yourself, is really tricky. Over 50% of discharges, even those that are planned the best and have, a great process, still over 50% of them have a medication either error or safety risk involved to them. You've all seen in your day-to-day work the massive gaps in communication that aren't there by intention, but there by the fact that our system across the U.S. is so fragmented. And so if you look at care management, you look at what we're trying to do here with this, and you listen to the practices that have been working on this in CPC Classic, or if you're new to CPC, you've probably thought about care management or already have an up and running care management program. And I think it's really about making evident your intentions to provide coordinated care. I think it has you shift your work to become to incorporate elements of prediction. So who do we predict may be facing some rough roads ahead? Who do we predict might be getting sick in the next 6 months? How can we more proactively address that? How can we get in front of the known risks of complications that you have right after a hospitalization or an ED visit. There was a big paper even yesterday about the fact that there are probably something on the order of about 10,000 deaths a year in the U.S. that happen in the first week after an ED visit, meaning someone's discharged from the ED, not deemed to be necessary for admission, and most of those are actually not cardiac. We do a pretty good job in the U.S. in ruling out for MI. And I think we all in primary care sort of know that. It's amazing how many people get ruled out for an MI, and that's a good thing. We don't want MIs, but if you look at the list of diagnoses that were most common amongst this cohort of people, and it's about 0.1% of emergency room discharges, people die in a week. It's cough, it's pneumonia, and it's confusion, and only a proportion of those are cardiac. And so I think we think about our post-discharge and our sort of care coordination work, and we think about this as really an opportunity for safety, as an opportunity to be proactive, whether you're responding to the episodic event or whether this person is in longitudinal care management, which means you've predicted that they over time will be a high utilizer or at risk of an adverse event. But and this involves a lot of work, Amy. It involves changing your workflow. It involves meeting, first of all, assigning staff to be care managers. It involves meeting regularly as a team to go over people who are recently discharged, to proactively plan for those who are in longitudinal care management. And it also involves having a process, a connection with your local area hospitals, whether you're in an integrated system or you're, a solo practice or, part of a small group of practices. You have a set of hospitals that most of your patients go to most of the time. And if you don't already have a process for having an information feed or a connection or a way of knowing that your patients were in the hospital, that's better than just, receiving some information from the patient 6 weeks later or from the insurance company 6 weeks later. You're going to want to develop that. And that's going to take some work, so let's not pretend that it's without work. But ultimately, I have found in my practice, we have found in our work across CPC that the work that you invest in this critical function will give down the road massive benefits to your patients, your families, to your workflow, because you'll feel less behind the ball and more getting out in front of things. And it's also an important signal to your patients, their families, and your communities that you respect that these are important, difficult times, and that you're doing all that you can, not just waiting for people to come to the office visit or call you, but you're doing all this proactive work to really improve their lives.
Yeah, I think what you're describing, Asaf, it really does then make the next step for primary care practices to really demonstrate to patients that they are the hub of care for them, that they will be there for them and support them no matter whether or not they're in the hospital or if they're in the skilled nursing facility or if they're going back home after an accident, that really all the care should be driven back to that team that's there to support them no matter what's going on, as you pointed out.
Absolutely. Yeah, a lot of this is about intention, and it's about, it's not rocket science, but it is hard work, and it takes careful planning. But it has this element of being really common sense. This is what you'd want for your family, right? You'd want your primary care office to reach out to you right after an admission, within 48 hours to figure out if you've got all of the meds that you need, if you understood the discharge instructions, if you have heat and have access to enough food, and a lot of our patients, that's what's on their minds. They want to adhere to the plan, but, they're working with a set of competing priorities, and I've had a lot of patients tell me, I want to make it to that follow-up visit. I got to make sure I put food on my kid's table beforehand, and I get that, but at least you've been able to identify that challenge with, with the process in which that for every patient that is seen in an emergency room and discharged or discharged from a hospital or skilled nursing facility that about, you've built in a process that within 72 hours they're going to get a phone call from one of two staff members in your office and that there is a mechanism for those staff members as your care managers to intersect with the teams, update the teams, think about what we're doing for these patients, and get people into the office that need to be seen in the office in a short amount of time.
Exactly. So Daniel, let me ask you. So we heard Asaf just reinforce what you already said, that you need to have this as part of your workflow. You need to add staff that are dedicated to doing this. So when you started implementing care management, how did you start to delegate roles and responsibilities, specifically across the different types of care management between episodic and longitudinal?
Yeah, I'm glad you asked about that, because I agree with Asaf that element of it is paramount to this work. So we do have about 90 to 95% of our patients risk stratified under the AAFP, the American Academy of Family Physicians risk stratification model, and that is comprised of a 1 through 6 risk level system, with 1 being very low risk and 6 being end-of-life type scenarios. And we have 5 clinics, as I mentioned before. We have 5 care coordinators at each of those, we have 5 care coordinators total, 1 assigned to each clinic. And our care coordination team has a variety of different backgrounds. We have, we used to have an MA on staff. We have an RN. We have folks with social work backgrounds. We have social services folks. And the reason why we built the team that way is so that we could really kind of complement the work of the medical team, so the nurses and the physicians and other practitioners, as well as complement the work of the behaviorists that we have co-located at our clinic. So we're all kind of working together as a care team. But the care coordinators, there only being 5 of them, we can't really expect them to do outreach to all 30,000 of our patients as they, leave the hospital and ED. So the protocol calls for our care coordination team to do outreach with those level 5 and 6 patients. And we're lucky enough to have access to a program called Pre-Manage, which allows us to see hospital discharges and ED discharges with 100% of the hospital systems in Washington State as well as Oregon. And so we can do outreach within 24 to 48 hours upon discharge. But that leaves a whole nother collection of patients who are lower risk, who also need outreach and need connectivity to their providers upon discharge. So we built a panel coordination team comprised of 2 wonderful women who use an automated dialer to do outreach to our patients level 1 through 4 who are not enrolled in care coordination actively. And through that, we saw a dramatic reduction in hospital readmissions in 2015. In fact, one of the payers brought this to our attention that we saw a 35% reduction in hospital readmissions.
That's fantastic. That's super impressive. So, Asaf, we heard Daniel mention risk stratification, talked about a risk stratification tool that they're using. Clearly, it's very important to care management. So let's just take a step back, kind of level set. Talk to us. What is risk stratification, and why is it so critical to care management?
Yeah, absolutely. So, and I'll go ahead and answer that question, and then we've been monitoring the great questions coming in, so maybe I'll answer your question, Amy, about risk stratification, and I'll just try to take on a couple of common themes we're seeing across some of the questions, if that's okay.
Sounds perfect.
Okay, so risk stratification, right? Let's unpack these terms, because like I said, so much of care management in my mind is just about getting the intentions and the direction right, and then kind of figuring out the terminology. So risk stratification is basically, it's a planned, intentional, proactive process that you carry out at the practice level. So that's really important. This is not done for our intents and purposes here, it is not done at some health plan level or at some CMS level. It's done at your practice's level. Now, it doesn't mean it can't be done at a larger level, but we've found that it works best when you go about it with your impaneled list of patients. So you take this process and you basically are engaged in a risk prediction. And then so you should ask me, so what risk am I trying to predict? We're trying to engage in a process where you're finding your patients who are most at need for care management services, meaning that they're very sick or they're about to become very sick, and that there's something reversible, preventable, amenable to your outreach. So that's not to say that there's just one disease group that we have in mind. Look for all the people with congestive heart failure. Look for all the people with dementia. There are obviously a lot of disease groupings that would fall into the category of people who are at high risk of needing a lot of inpatient care, a lot of specialty care, a lot of utilization overall. We're trying to prevent preventable utilization of services, but more importantly, we're trying to make people's lives better. So there are obviously many conditions in which we're all going to get really sick one day, and some of that is just not preventable and not amenable to change. And there are other ways we can go about helping them with end-of-life care, et cetera. Care management is really for people who are in that sort of high-utilizing phase where they're the folks that you're thinking about all the time, that you're seeing all the time. They tend to have multiple serious chronic conditions. They also tend to have, often but not always, concomitant behavioral health issues, whether they be mental health, depression, anxiety, schizophrenia, or substance abuse, or both. And they often, but not always, will have challenges in terms of poverty or difficult life circumstances. There's no one category, but what we're trying to find is a process for you to engage in a structured process, to look at your panel, find a group of patients that you're worried about, that use a lot of services that you can help. And then you create a proactive outreach mechanism in a small team within your practice to be that effector arm, that touch point for this group of people that that you believe that are at risk. So that's what it is, Amy, in a nutshell. We're getting a ton of great questions. I love the engagement. One of the questions that I keep seeing around is who is the right person to be a care manager? Like, what's their licensure? What's their credential? There's not a hard and fast rule about that. What I can tell you is that there are a lot of ways in a lot of different communities, in a lot of different practices to answer the question. But what we have found in general is that the following two types of providers are probably not the best people to do care management. So doctors are probably not the best care managers. Now, that's not a hard and fast rule. I know that there are some very small practices that have very limited staffing, and I get that that might not always be the case. But in general, doctors don't make the best care managers, A, because they might not have the requisite skills, and they might not have the requisite time. The second group of people, and this is, again, not a hard and fast rule, but just based on observations in hundreds of practices, is that medical assistants generally, but not always, don't make the best care managers, not because we don't love medical assistants, but because they often don't have quite enough clinical background to problem solve, kind of know exactly when and how to ratchet up the clinical interaction level to the team. There's another frequent question we get, and I'm seeing it all over the question area, which is, what is better, especially if I'm part of a system? Should I have care managers that are on site, or can we utilize off-site care managers, let's say at the system level or at the health plan level? Again, I'm not going to give you a hard and fast rule, but I'm going to give you, from over a decade of experience on this stuff, observations and data. There is a fair amount of data on this that suggests that embedded care managers most often LPN and RN level, but I'm not going to, say that it has to be those, but those are the most frequent, are more effective in providing outreach, connection, and counseling to patients within a practice than care managers not embedded to a practice, and especially care managers who only have access phone-wise to patients and don't have access to their EHRs. So they are almost never as effective as the alternative, which is an embedded care manager with access to the EHR embedded in the practice. So I've just gone on a fair amount there. Amy, I'll turn it back to you, but happy to keep trying to answer these great, super engaged questions.
Yeah, there's fantastic questions coming in. Keep sending them to us. And in the spirit of answering those questions, I think, Daniel, this is a perfect time for you to jump in and tell everyone, how did you start to implement this risk stratification algorithm that you described? You said you're using the AAFP model. Did you just plug that into your EHR and all of a sudden all your patients were risk stratified? How does that happen?
Well, I think that would have been nice if we were able to do that initially. Unfortunately, it took a lot of front-end work, but it's really paid off in the long run. In fact, it is a manual process, and when I tell other groups who are beginning risk stratification work or have existent risk stratification driven workflows, they kind of blanch that we're doing it manually. But to be honest with you, we wouldn't prefer it any other way, because if there's a automated way to do it, then essentially the EHR is just pulling things off of the problem list and coming and spitting out a number. Whereas, according to the AFP model, it really allows for the provider to use their clinical judgment when assigning a risk level and take into consideration other factors that aren't going to be in a typical EHR system. For instance, homelessness barriers and socioeconomic status and that sort of thing. So we're really pleased with the way that we're set up currently. But the initial implementation, we began by kind of having one of our quality managers going through and doing chart reviews and assigning risk level to the patient. And we were super lucky in that around that time, Greenway, our EHR manufacturer, implemented a risk stratification functionality in the EHR system, just a 2-click model. And so at that point, we switched gears. We let everybody know everybody had already known what our intention was, because we'd held several meetings prior to that. But we let the providers know that the expectation is that we have to have, at the very least, 75% of our patients risk stratified. At the time, that was the CPCI benchmark that they had in place for us. We have it set up currently where if a certain provider falls underneath that 75% benchmark, then we'll supply them with a list of patients who haven't been risk stratified, and then they'll have to spend their time doing that, which nobody wants to do. So our providers do a pretty darn good job of staying on top of that. But also it helps that it's such a simple process in our EHR, so I encourage folks to work with your EHR vendors and have them implement something like that if they haven't already. But to date, we have about 90 to 95% of our patients risk stratified, and we couldn't be more pleased.
And Daniel, just to be clear, that's all the patients in your practice, not just the patients that are attributed in any way to CPC Plus, right?
That's absolutely correct. 90 to 95% of our 30,000 patients have been risk stratified at this point, and we prefer it that way, so that way we don't have two separate lines of folks that we're treating differently. But also, I should say, we have a huddle sheet in place that the provider and their nursing team look at the beginning of their day, and they can see we have a column on that huddle sheet that lists the risk stratification level. And if a patient hasn't been seen before, obviously that's blank, and they'll go in and either write it in or manually do it in their EHR at the end of the visit. But it also gives them an idea of who's coming in that day and what kind of, at a glance, what kind of resources this patient's going to require.
That's great. Well, let's move on to the next slide. And I'm not going to spend a whole lot of time talking about this because, Asaf, you did such a great job really explaining this. But just to drive home again, that longitudinal care management, that relationship-based care for those patients that really can get the most out of that additional service that you're providing them to help coordinate their care, to be proactive in those touch points. I mean, a lot of you have seen this model before. The more intense the patient's needs are, the higher their costs, and most likely the lower their health status. So for a lot of people, in the medical home world, they'd say that's kind of the sweet spot for medical home. When you really start to transform the way you're providing care and you implement care management services in this way, you can have an incredible impact on these patients. So it's talking about this really, intentional care, the patient knowing that you're there for them, that you're reaching out, you're anticipating often what their needs are going to be. And then also to add into this is that really using a care plan to guide this care so that the communication about what's going on is known not just to the care team, but to the patient and to the other people that are involved in their care. So that's another important element, and certainly another place where your EHR and Health IT can really help in creating that care plan and providing opportunities to share that information so everyone knows what the goals are, they're shared with the care team and the patient, and that everyone understands what the expectations are and what to do when there is a crisis. So I'm going to, in the essence of time, let's move on to the next slide.
Amy, I was wondering.
Go ahead. Yeah.
Here. I was wondering if we could go just to slide 8 because I'm seeing a lot of questions and I want people to really feel like this process is described in its nuts and bolts. So we talked about what risk stratification is, and what it means in practice, as Daniel described, is basically you take a set of criteria. That could be something that's built into your EHR. It's important to work with your vendors because a lot of your EHRs already have some sort of algorithm that's built around counting comorbidities or counting severity or counting, it has an identifying flag for a bunch of severe types of X, Y, and Z. So there are a lot of ways to do this. Some of them count the number of drugs that they're on. Even some integrated systems can look at number of hospitalizations. We think that there's a process that you can engage with your practice leadership, with yourselves, to figure out which of the algorithms that spit out a ranking might make sense for you, and attaching an initial risk score to your patient, something that's flagged within the EHR. Getting a lot of questions, does that mean that we have to sit there going manually through each of our patients if we have 10,000 or 20,000 patients? Most often this can be an automated process, and we can work with your practice to figure out the best starting algorithm. I think the thing, especially for Track 2 practices, but even for Track 1 practices, to think about is that, and the evidence is there for this, is that when you add a second layer of what we call clinical intuition, that means that your teams look at their list of stratified patients that have in order of highest to lowest risk, and they look at, let's say, the top 10%, and they take the time, and this takes actually less time than you think it might. You take the time to look through a couple hundred patients, and you don't sit there like looking them up each one by one in the EHR. You look at the list as just kind of a single line, and you make a sort of summative or gestalt or sort of gut intuition or prediction that says, yeah, that person's pretty sick, like given everything we've talked about, lots of comorbidities, some life challenges, maybe some behavioral health stuff. You'll find that you go down that list and maybe 80% of them that the algorithm came up with, they'll totally make sense. But maybe 20%, you'll just be like, how did that person get in here? That person's not that sick. I've known him for 25 years. He's fine, or, he just had a bad year and things are getting better now. But then you think to yourself, oh, but there are all these other people that somehow didn't make it on the list. The people who maybe you haven't seen in a few months or a few years, but are facing a lot of challenges, or the people in and out of the hospital that you want them to come in and you want to engage with them further. Those people really benefit from your intuition to be like, yeah, they should be on the high-risk list. Because, again, I'm trying to prevent my sick patients from getting sicker, and I'm trying to predict a group of people who will respond to that outreach. So, again, I'm trying to encapsulate a bunch of your questions and sort of roll them up into one here. There's some really great questions, and this is a process, And, again, there's some upfront work. There's no doubt about that. But once you can, especially for your longitudinal list of care-managed patients, have, a lot of people have been asking about ratios, certainly no more than 150 or 200 per care manager, probably a little bit less. You've got that list, you're targeting your outreach, and then you've got with your episodic care management, your abilities, your day-to-day standard work processes to follow up with anybody who happens to get sick or have a care transition. Because we all know that anybody can get pneumonia, anybody can get a DVT. There's just going to be a bunch of people who are healthy one day and the next day have a care transition, and your practice needs to be prepared to help them in an episodic way. But they may just need a couple phone calls and maybe a short-term clinic visit, and they're on their way and they're back to being their healthy selves. Whereas there's that smaller group of people that you're worried about, you're working with on a day-to-day basis, you're reaching out to often.
Right, or maybe there's a patient who went into the hospital and was relatively healthy before then, but then as you see during their transition, that they really do need some more longitudinal care management as they start to, have other complications perhaps from their illness. So it can go either way. All right.
Yeah, I was also going to say that episodic and longitudinal care is incredibly important because, to echo what you said, Amy, and Asaf said, a healthy patient presents to the hospital or ED, but they're presenting for suicidal ideation or something like that. It's important to have processes in place so that you can catch that and then give them a deeper level of care. Additionally, a way in which we kind of have the two-step risk stratification process set up is the risk stratification level drives our workflow, and if a patient is a level 5 patient, we have them actively enrolled in care coordination, meaning that we have a care plan written for them. We have a set number, the risk stratification level determines how frequently we're following up with that patient telephonically. We're checking in with 5 and 6 patients every month, our care coordination team, and our level 4 patients we're checking in quarterly or more as determined by the practitioner or the patient. Additionally, we're updating care plans based on the risk stratification level. So 5 and 6 patients we're updating quarterly. Level 4 patients enrolled in care coordination we're updating biannually or as directed by the provider or care coordination discretion. So the way our care coordinators are involved in the risk stratification process is they can always increase a patient's risk stratification level. That includes our panel coordination department who reaches out to the lower risk patients by notifying the provider that they've done so. But in reducing the risk level, since that determines how frequently we're checking in with them and getting them in to see their provider, we need express permission by the provider at first. So we'll often send the provider a message and ask them if it's okay to reduce that level and then wait for them to respond before we do so.
And clearly you've been working on this for a long time and really finessed a lot of the way you've been managing your patients, the way everybody knows how to make referrals, if there's patients who might not have been originally risk stratified or if they're changing their status. So I think everyone should look to your practice as a gold standard to say, like, we can do this, we can achieve this. But it is going to be incremental, and there's a lot of work, no doubt, that went into your workflow and your processes along the way. So
yeah, that's very true.
Yeah, go ahead.
Oh, that's it. I was just going to agree with you.
Yeah. So let's skip over back to slide 10. I do want to give Jen Miller, who's with us, a chance to introduce herself a little bit and talk a little bit more. I mean, we've been going back and forth talking about episodic care, longitudinal care, but I want you to just kind of maybe hit on some of the high points that we haven't had a lot of time to address, Jen.
Sure. Thanks, Amy. So I was working with practices facilitating during the CPC Classic program, and now have the opportunity to work on the national learning team here with CPC Plus. And so in my experience with Classic and episodic care management, typically practices define that as a period of time working with patients between like 30 to 90 days. It encompasses a broad range of services and environments designed to promote the safe and timely passage of patients between different levels of health care across different settings. And basically this would be like patient transitions in care from an inpatient hospital setting or a skilled nursing facility back to the patient's home community setting, whether that's their home or an assisted living community. The person in the practice who provides episodic care management, and we've had some discussion about this already today, but I think this is where it differs a little bit from the longitudinal care management. And like a soft set, a medical assistant may not be as clinically in tune for some of the longitudinal care management, but again, that's not a hard and fast rule. Those types of roles, and even I've seen practices including possibly front desk staff who can do basic outreach for episodic care management for, say, ED discharges if they're following a script that basically has basic follow-up questions. And so I was going to maybe walk you through a quick example of what this might look like. So let's just say, for instance, John Doe is seen in the ED, and so then his primary care office receives a report that shows that he was seen. And this can be done, as we described earlier, through like an HIE, a health information exchange, if you use that, or some sort of process or care compact that you've arranged with your local hospitals. So then this starts a standard process where the designated staff member who's assigned to the ED discharge follow-up reaches out to that patient via a phone call. And they may follow a predetermined template with some questions on it, basically to ensure that the patient understands their discharge instructions. And this may include medication reconciliation, follow-up tests or services. And it's also an opportunity to update the care plan, possibly initiate some self-management support, and or provide education to the patient and family about that condition, in addition to services that perhaps the office could have provided that might have prevented that ED visit as well. So that's been my experience with the episodic care management piece.
That's a great example. I want to move us on to the next slide, and Jen, I think you can kind of build on that and talk about the role of health IT in care management. We've heard a lot about it in terms of how it can be helpful in risk stratification and some other management processes, but tell us a little bit more about how technology can assist.
Yeah, technology can be a great assistant, but I know it can be daunting for people as well. But just to kind of let you realize the benefits, technology offers a host of opportunities to make care management more effective and efficient, as already described with risk stratification, as well as creating registries to identify populations with chronic or multiple conditions. And this can help to identify subpopulations for specialized treatment or identify gaps in care and unmet needs with your patients. Another area that IT plays a role is in monitoring and evaluating your care management efforts and outcomes over time. And I know that this can be difficult, but it's really important. So you can set it up to do some reports that are analyzing how your care management efforts are working to improve your patient population, as well as maybe finding ways that you can tweak your workflows. And most importantly, Health IT can enable your care team to target your services appropriately for each patient and help integrate these services into the workflow of your practice, really providing proactive care management.
Fantastic, Jen.
Yeah, Amy, I just wanted to take a second to build on Jen's comments and also try to answer some of these, again, great questions we're getting. And I love the sort of direction and the hunger for details. You know, the one thing we can promise is that your detailed questions, you know, we will definitely be able to answer. There are a lot of questions about do we risk stratify everybody in our practice, or only the Medicare patients, or only a subset? So just wanted to clarify, you want to risk stratify everybody. Now, that means that your target for the number of people, especially in longitudinal care management, that you'll end up managing is probably around 3 to 7% of your total population. So you don't want to be left with a list of 1,000 patients because you don't have the resources. Some of you have also asked questions about, well, where do we get resources for care managers, and that's actually part and parcel of why this is so tied into CPC Plus. The extra resources that come along with CPC Plus are in large part meant to augment the resources that you have to be able to hire or repurpose or augment your staffing. There were a lot of questions about, if we have a risk score that we get for Medicare patients, so it's called HCC, is that enough? And we would say that's a great start, and if you could make an HCC score for everybody, as some EHRs can do, that's a great first step in the algorithm. But again, to just reflect our goals here, we want everybody in the practice to be risk stratified, whether they're in Medicare or they're another payer. This is really a population level intervention, and what you want to be doing is thinking about your clinic as a population. Some of you have also asked about how many patients does the care coordinator see in an average day. Care coordinator doesn't really see patients in visits. What they do is they do a lot of outreach on the phone. They may coordinate a bunch of stuff. They may say hello to them when they walk in the practice, but they don't really see patients like visit by visit. And finally, a lot of people have asked about the number of, these guidelines about what is an interaction within a week of emergency room discharge, how does that work? And we'd recommend that be at least a phone call, but ideally in the literature would suggest that certainly for the patients undergoing a major care transition, like coming out of a long hospitalization stay, that a visit to the practice within a week is a really good idea. A phone call within 72 hours or 48 hours of discharge is critical too. Many practices have started calling their patients in the hospital as well because they have an information feed, and that just even more augments the successful discharge process. So just trying to answer some of your excellent questions in the moment and just build upon this, from the theoretical all the way to the practical.
Yeah, Asaf, thanks so much for doing that. You're doing an excellent job of monitoring the questions and getting those quick responses in. And I know you're going to have so many more questions. So let's just do a quick review of some of the resources that you already have available to you today. So, of course, you've got your list of care requirements. You've got your roadmap that was in the first phase of your implementation guide. The next phase of that implementation guide is going to have much more information. That's going to be coming to you very soon. But you also have your change package too, and please do go and reference those materials. One other resource that you have available to you now, we've already got lots of chatter going on there, is CPC Connect. So go to CPC Plus Connect. After this webinar, when you have some downtime, there's some great engagement going on. Share your ideas, your questions on there as well. And then, of course, there's more learning opportunities coming to you. So if you go to the next slide, we've got several things that are coming up. We've got more action groups that are coming to you. We've got all these learning opportunities that are scheduled. We've got webinars coming up. And depending on where your priorities are, we would ideally like to have at least one individual from each practice in CPC Plus participating in all of these events. But if there's one that you're particularly interested in, you might want to let some other of your office staff know about. So I do want to make sure we have some time for our CMS team to respond to some of your policy and payment questions while we still got a few minutes on the call. So Gabrielle, I'm going to turn it over to you and your team.
Thanks, Amy. Okay, guys. So we got a few questions. Yeah, we got a lot of questions. And again, if you have more questions, please email us at CPC support. So payment. So many of you should have received your payment last week. If you did not, you will receive your quarter one payment in mid-March. Excuse me. And that is due to some processing delays. So thank you for your patience. Your attribution lists. Many of you have a lot of questions about these. These are available in the practice portal already, and if not today, then tomorrow for sure. Which brings me to my next question is, when will I get my portal access? Thank you all for your patience. We are still processing the very long queue of portal requests. There are multiple approval steps, and if you mess up one, you unfortunately have to redo it, so it's taking some time. We know you're all anxious to get in, and we really want to help you get in there as quickly as possible, but appreciate you working one-on-one with CPC support to get your access. Another follow-up question, your attribution list will contain beneficiary level information, including their names and other PII. So those were the hot topics. Again, if you have more questions, please join us at our office hours, post on CPC Connect, and contact CPC support.
Fantastic. And I know we just have a minute left here. I do want to thank everyone so much for joining us today. I know all your practices are super crazy busy right now. 'Tis the season for flu and all other kinds of bugs going around. So I do really appreciate the time that you've given us. And I really do want to ask you to take just another minute to respond to our evaluation that'll pop up here in just a minute on your screen. We truly are committed to making whatever improvements we can because we do value your time and we want to be here to support you in your efforts as you progress through CPC Plus. So whether it's your feedback on how we could do a better job of delivering you information specifically on webinars like this or in other places, please do fill out the survey and let us know. And we'll certainly be chatting with you, again, as was mentioned, through responding to your questions directly to CPC Plus support and through CPC Plus Connect. So we look forward to talking with you very soon. And thanks again, everybody.
Ladies and gentlemen, thank you for participating in today's webcast. This concludes the program. You may now disconnect. Good day.